one thing that I just wanted to pick up on, which I think is important that you mentioned, is breast cancer subtype. And I think certainly both the hormone receptor positive and triple negative settings are areas where we're using PARP inhibitors in the adjuvant setting. And for my practice, I really don't differentiate too much between the hormone receptor expression status and whether or not I'm testing. I typically use the other criteria that you mentioned to drive my testing. But I want to confirm with you, is there an impact in terms of hormone receptor status and how you look at the testing approach or identification of candidates for PARP inhibition?
Not for me. I think that there has been one of the first clinical pathologic observations was the association between BRCA1 mutations and triple negative breast cancer. I mean, and that, again, historical perspective, that observation came pretty much at the same time as triple negative breast cancer was being recognized as a distinct clinical pathologic subtype, with its own clinical behavior. And so those two things got kind of merged in people's minds, BRCA1 plus triple negative. And the other thing that happened is that because of the discovery process, BRCA1, which was discovered first, wound up getting more press. And so people didn't think much about BRCA2. I mean, it just was always kind of the add-on. The fact is, BRCA2 mutations are as common as BRCA1 mutations. It is true that 20% of BRCA1 carriers' cancers are triple negative, 80% of BRCA2 carriers' cancers are hormone receptor positive, but that is actually somewhat age dependent. As BRCA1 carriers get older, their cancers are more likely to be hormone receptor positive, and as BRCA2 carriers get older, their cancers are more likely to be triple negative. So it's difficult to use subtype. And again, there is benefit from PARP inhibition in hormone receptor positive and triple negative settings. So I don't think that we should be discriminating anymore. BRCA2 kind of got left out in the cold a little bit. But in some ways, it's more dangerous. There's a wider spectrum of malignancy associated with it. There's a very high risk of prostate cancer. There's a modest risk of male breast cancer. There's a decent-sized risk of pancreatic cancer. And BRCA1 is largely breast and ovary. So leaving BRCA2 off the table, and you'd only identify those if you tested a lot of hormone receptor positive patients, would mean that you would potentially lose a lot of opportunities to help.